So welcome everybody. Thank you for coming to what I think is a very important discussion which sits at the intersection of healthcare and AI, which is patient confidentiality and privacy. As AI continues to transform healthcare, the privacy and protection of patient data becomes very, very critical, and it becomes more and more difficult. And today we are joined by three distinguished experts who have spent a long time in making sure that AI in healthcare remains ethical, remains compliant, and provides privacy. They'll talk about some of the regulatory, the technology, and other aspects of it. And I think this is going to be an important discussion. We will have interactive discussions. We'll open it up for some questions. I'm going to start by asking them to introduce themselves, and with a simple question to all of them. And the question really is, what are some of the biggest challenges and opportunities that each of them, because they all come from different backgrounds, sees in terms of protecting patient privacy and confidentiality in AI healthcare? And I'm going to turn it first to Hadassah.
Thank you so much, Sanjay, and thanks so much for the invitation, of course, also. It's great to be here, great to be a part of this panel session. My name is Hadassah Drukarch. I am the Director of Policy and Delivery at the Responsible AI Institute, originally from the Netherlands, so it's great to be home again for this conference. But we're a US-based, member-based nonprofit organization that aims to advance responsible AI practices within organizations, both in industry and government. And when it comes to industry, across different sectors, think of healthcare as one example, but we also work with companies in energy, finance, tech-native, non-tech-native organizations, essentially providing them with the tools and resources they need to go from the what and the why of responsible AI into the how. So providing them with the right methodologies to implement ethics and ongoing regulatory requirements. And that immediately, I would say, relates to the biggest challenge I foresee, right? It's that moving from understanding this really high-level principle-based approach to what it means to do responsible AI, to develop, deploy AI in a responsible manner, generally, but healthcare being such a sensitive domain of application, of course, in particular, into what methodologies do we actually use to implement, what metrics do we use to test and to understand how we move from A to B. So I would say that's the biggest challenge, and I'll keep it short.
The opportunity.
Oh, the opportunities. Yeah, it's always easy to start with the problem, right?
There's some positive reinforcement to folks too.
Yeah, I mean, I think, good point. I think it probably is not surprising, right? I think it's very clear that, especially in the healthcare domain, AI has a lot of potential to improve the way in which care is delivered, not anymore only, at the top-down level for a patient entering into the healthcare system, but also really at that ongoing basis, all the way downstream, being able to not only enjoy the benefits of care delivery when you need it, but to be able to maintain a balanced health care, I would say a balanced care throughout your life through the new tools and applications that we're seeing. So I would say that's like one of the benefits, but there are plenty, and I'm sure that everyone's aware of those.
Shravanthi.
Yeah, hi. So I'm Shravanthi. I work with a company called Commonwealth Alliance, which is based out of Boston, and we provide Medicare and Medicaid services. So we are healthcare providers, but also take care of the care management part of things. So dual right there. So I work in the data science. So I lead the initiatives and work as a bridge between clinicians and the tech team out there. So we basically help in that layer of building, risk models for creating that triage for a better patient outcome or a better care management, and help, come up with different programs which could help understand a patient from a population perspective and cater their programs for their own. So I work on that area, mostly with clinical and a lot related to behavioral and social health as well, where the topic comes now ethics and privacy, because first of all, patient data and maintaining ethics while moving into AI, that is a big thing that everyone needs to consider. But when it comes to BH data specifically, that could also be one of the challenges. BH data has a lot of risk of re-identification. people try using these external markers and everything and try, mapping patient back, no matter how much aggregation you try to do. I see that as one challenge to begin with. There are a lot more, though, dealing with privacy. And talking about challenge, I would, no, not challenge again. Opportunity. So opportunity, I would say, with this predictive modeling and a lot of things in place, back when we compared like 6 to 7 years back and now, people have started adopting risk models and clinicians have started accepting it and using it as well. So with this, we're able to give better care to people and react faster as well. So I would say that is one of the biggest opportunities.
Awesome. Sigal?
I don't have a microphone.
Okay, there we go.
Hi, so I think most of you heard me before. So I'm Sigal, I'm the Director of AI Data and Digital Innovation. I work inside Hospital Trust in the UK, in Guy's and St Thomas, but other trusts as well. And also run the Artificial Intelligence for Value-Based Healthcare, which is a consortium of organizations. And we develop AI models in actual real-world clinical care and research and innovation. And again, some of the challenges are around anonymization and patient safety in kind of creating some of these large language models. Just a really practical example, 4 months ago, hackers hacked our pathology systems in Southeast London and had a ransom that we wouldn't pay, and we reverted back to manual processes. We couldn't carry on operations, blood transfusion, and match patients with their blood. That is absolutely super serious, and people did die, so we reverted to manual processes, and we were able to bring back the systems. But it just shows you how vulnerable we all are to these type of things, and we really need to consider that in terms of how we frame the whole kind of, not just the ethical but the practical considerations of patient data, because some of the patient data was then published on the dark web as a consequence of that. So it's a very serious matter. But I'm obviously an advocate for AI because I can see the impact it makes, and those of you who heard me talk about it before, I gave some examples of that. So I'm prepared to show some of the practical ways of how we're dealing with it.
Awesome. So we'll get into public share. So let's get a little bit deeper, and we'll start with you, Hadassah, that you have a background in governance and regulation. How do you see current regulations evolving in terms of protecting patient data and privacy, given the pace at which the technology is changing so rapidly? I mean, from the time ChatGPT came out to now, you have agents, you have multimodal, etc. How are those frameworks evolving? So can you tell our audience a little bit about that?
Yeah, absolutely. I mean, I'm all for being transparent, so I'm going to be very, very honest and frank. In the current landscape that we're in, I think a point of departure is that privacy confidentiality is one of the core tenets when we're talking about regulation of AI in general, right? It's not. It, to some extent, can be seen as a standalone item, component, but to a large extent, it's part of a whole, right? When we're talking about responsible AI, it consists of many different principles and aspects, core values that, at least, let's take it from a Western perspective, we believe should form the foundation of developing, deploying, and using AI. Privacy is one of them, but it relates to transparency, it relates to cybersecurity, it relates to all of it. So I think that's potentially an issue that we're seeing, but it's also just the necessary context to understand what regulatory developments are going on. I think the advent of, or the creation of a hype around AI, and I think the fact that we're all talking about AI right now is taking away the understanding that privacy and confidentiality, of course, has been a topic that long preceded a lot of the discussions we are having right now, as everyone probably is already familiar with. There are a lot of regulations around, there are some core pieces of regulation around privacy and data protection in the EU. We see it in the US as well, also in the context of healthcare, of course. In addition to that, what we are seeing more recently is with AI becoming such a big topic and the acknowledgement of the great impacts it will also have in healthcare, beyond these more general frameworks that we're seeing. Think of the EU AI Act, which to a large extent is, of course, industry agnostic. think of the regulatory developments in the United States with the executive order, with state-based legislation. We're seeing very little direct attention to patient confidentiality and privacy and data protection. What we are seeing, though, is I think at the level of, think of the US, the agency level, think of the FDA as an example. And here I recently became aware of the European Medicines Agency that is setting out essentially a roadmap and a set of guiding principles on what regulation in the age of AI should look like, privacy, confidentiality, and data protection being a big part of that. But I think at this point in time, the reality is there is still a lot, or a very big lack of clarity around that industry-specific application. It's just, you know, the way it is. I think we're seeing, and possibly, I mean, I'm not a great fan of making predictions, but I think the US is actually positioned in a really nice place, given the approach that the EU is taking with this broad kind of like blanket regulation, blanket legislation. I think they're actually in a good place to build more industry-specific requirements, more industry-specific guidance and requirements on how now we move from like that, you know, high level, what I just said before, right? What, you know, the what and the why into the how, and privacy, data protection, and patient confidentiality are part of that. Yeah.
So just a quick, okay. In the US, we have the HIPAA, as you know. In Europe now with the EU AI Act, and Sigal can jump in. Do you think HIPAA and regulations here, you have GDPR, are capable of protecting patient confidentiality from a healthcare standpoint, or do you see improvements that are needed in there?
Yeah, I think, I definitely think that these, when you look at the GDPR, right, that's mainly my, I think, given my background, a piece of legislation that I've had like quite some experience with. Of course, at the core, the intention is to protect patient, or confidentiality and protection of data of individuals in general, right? Patients are part of the data subjects that we're looking at. I think with AI coming in place, beyond protecting one's data and understanding what the legitimate basis is for using data, there's also a whole question around, you know, how can we now move on using data for other purposes than primary care, but also, for instance, for research, innovation, regulation purposes. We're seeing the European Health Data Spaces regulation or legislation also, which has caused a lot of discussion, and especially because of the disconnect between that and the GDPR, as an example. So I think there's still a lot of work to do around that. I would definitely say, though, that as we're looking at this space right now, I've kind of like lost the point that I wanted to make, but I'll get to it. I think what definitely is necessary, and maybe you would have like a little bit more insight, you know, given the practical way of working with it. I definitely think there needs to be some improvement in aligning efforts, as opposed to just trying to say like, you know, we have one piece, we have another piece, we have another piece, now kind of like figure it out.
Okay. Sigal, jumping to you, you are leader in AI and data at NHS. What tools and strategies do you use for anonymizing data? And can you explain that to our audience? Because that's an important aspect of what we try to do here.
Sure. Is this working? Can you hear me? Okay, great. So we have a number of things you have to go through before you start using AI for research, and indeed for direct care is a bit more simple because it's run within the kind of secure data environment of a hospital trust or an organization. But when you're using AI or any kind of research, it goes through a process where you go into a governance data board, data allocation committee, which has key people that are sitting on it to approve those projects. But also, so those projects have a lifespan, for example, so the data will have to be anonymized. It might need to be deleted after it's used, and all sorts of things like that that are really dependent on the project. Anonymization is done in a way that ideally you won't be able to trace back the patient with the real data. And there's other techniques like pseudo-anonymization, etc. But again, there are some vulnerabilities with that. Anonymization does work, and there's great techniques, but some of the things, for example, with medical imaging, we have to mask because some of the ultrasounds images have the date of birth of the mother and the NHS number, etc., burned on the image, so you have to mask that. And when it's video, you can't just mask it effectively. So that's just one example where there are some ways that it's very difficult to anonymize patient data. The other thing about patient data is that it has parameters are unique, like your genomics data, etc. So there are issues with and really strict rules about the anonymization of that for research and for technology innovation that might involve industry partners and other. So again, there is a very specific use for that data to do that specific authorized use case. Rather than then, there's been cases where data was released for all sorts of companies and they sold it on, etc. And so we have to have those mechanisms in place, and we do at the moment as part of the NHS have very strict rules. But it does mean that the lead time between a project initiation and the actual getting the data into the hands of the researchers and the innovators takes quite a long time. So that's the kind of downside of that. There are, it's not just about automating it and making it faster. It's about the kind of approval process that you have to go through. So again, if we can find ways where that is kind of the safety and security is built from the ground up, and some of these things are more automated and done as a group rather than individually in each of the data controller, again, those are some things that maybe can be looked at from a policy and processes perspective.
Thanks, Sigal. Shravanthi, when you use real-world algorithms, what ethical considerations go into the use of patient data? Can you talk a little bit about that?
Yeah, I mean, before even beginning with that, you were talking about HIPAA, right? The regulations. I feel like even though it doesn't do all the things that we needed to do, like she mentioned already, but then it definitely adds in a layer so that whoever's working on it has that conscious of you are supposed to report these things out to, NCQA, or you have that privacy and conscious out there that you need to be. It's a patient-centric focus there. It's definitely because of the ethical regulations and oversight committees and other things out there. So I think added layer of advantage is definitely there when you begin working because of the regulations and different areas. Okay, yeah, so back to real world data. So talking about real world data, I feel like that itself is a place where there are a lot of data sources aggregated together. It's just so hard to get everything at the same member level and have all those data sources here and there and still follow the, data leakage and a lot of hacking things as well, because everything stays in a very different place. Because we work with providers, that's a different kind of area. And then we take forms, like for mental health data, like, how you feel and things like that, that's another source. So we have like n number of sources sitting here and there. And when you try aggregating, the first issue starts right there. Data aggregation, you have a lot of risk of re-identification as well. Like the more data you use, there's a lot more exposure. So the risk starts right from there, I would say. So then navigating to the problem of next, moving on to the fact of, from model to production or like post-production. I feel like the way we kind of deal or move through the things is try with aggregation methods and using anonymization techniques so that we can help reduce this reduction of re-identification of the risk. And then when we move on to the flow of post-production, everything is good when it's in the phase of POC, and then you move on to actually putting it into the system or seeing which member needs attention. Or this really happened some time back, like one of our models that was in POC, thank God, suddenly it started saying that no one needed a help, like a particular product, no one needed a help. We were like, no, that really cannot be the case. But when we went back and saw, it was just because of a leakage somewhere and, shift in data frames. So it's the small thing, but it wasn't POC. So the lesson is that tracking. So when you finish your model or post-processing, tracking, monitoring it to make sure that the risk is just less for all these kind of issues. And then another part is feedback. one important aspect is it's so hard to get the stakeholders buy-in, especially when they're doctors and all clinicians out there. So important aspect here would be like getting their buy-in. And one thing that would help is feedback. So feedback from them and try to loop in the system, so that kind of improves your model over time as well, and they have some confidence. And overall, you also help, with this smoother transition towards moving into this privacy. I would say these are some, but one of the main topic out there, bias. So with data and with data handling and specifically real world data comes in bias. So we try to figure out if first of all the bias is induced because of the model, or does it lie in the data itself? Is the population that way? We try mitigating it at the beginning by doing a couple of analysis and also by checking if it's first of all possible to mitigate that. But one way of making sure is that if it well represents all the different groups out there, at least there's no underrepresentation, and you'll it's a better, smoother transition that way. So we just begin with all of that. And on top of it, I feel like to make this process somewhere easier, having AI oversight committee, like a regulation out there, organization-wide, just so that there's someone who can, track and you're accountable to them. And there's this model that goes through all of these procedures before, when it's in POC or post-testing or post-deployment. So I'd say like some of it.
Yeah, that's helpful. Even the one point I'd make, I don't want to keep talking about HIPAA, is HIPAA's been around, 30, 40 years now? With no changes, and the world has changed since that time. So let's be realistic about that. But Sigal, NHS serves a very diverse population in terms of digital literacy. How do you make sure when you roll out AI applications while protecting, patient privacy, that you are serving, being equitable in terms of the way you serve? So can you talk to our audience a little bit about that?
Yeah, it's a very good question. I guess there's two sides of it. There's some of the systems, ideally, from a staff perspective, some of the things that we're used to seeing now are automated, so we don't even notice that they're kind of part of the system. And I think it's about also making sure that there is a good digital maturity within the staff. In terms of how patients perceive their treatment, certainly when AI is used for direct care. For example, I gave some example in radiotherapy where we are able to more accurately and speedily contour organs to really focus the radiotherapy in the right areas. The patient won't necessarily understand how we're doing that through the MRI, the CT scan, etc. They're kind of used to being treated by doctors and hospitals in a way that explains the condition, explains how you derived with the conclusion, and giving them options around the outcomes and how they want to be treated. The AI ideally enhances that in a way that there is an enhancement rather than an impact in any other way on their treatment. So it is important that there is a bit of an understanding from the treating physicians and the patients themselves in terms of those tools that are being used in their care. But I think increasingly some of these technologies are kind of used in the back end of systems without the clinicians necessarily realizing that. So again, it's about really understanding what those tools are doing and how and the transparency about how they derive into those conclusions. So I think one of the things from a regulation point of view is that we were talking about this a little bit as well, is that kind of traceability back into how do you derive to those algorithms. A lot of the marketplace, the companies don't want to necessarily divulge their IP in terms of how they derived those, but actually it is really important in terms of understanding clinical pathways and how the AI is influencing, like the example example you gave of the proof of concept, it actually, and what we're finding is that when we're adopting technologies from, for example, from the US, and when we're adopting them in a hospital in the UK, they're trained on a different population or a slightly different model that's more a kind of paid service or based on insurance, and they don't actually deliver the same results. So it is really important as well that we consider how those models are trained, and that they might need to be retrained based on local populations and a diverse population at that. What we try to do, again, I spoke a little bit about the federated learning interoperability platform that was built, and that, again, trying to train algorithms on multiple hospitals and multiple populations in the UK that will have that kind of diversity of population, so that to remove that bias ideally. Those are some of the technology ways in which we're trying to do that, and in that federated way, the data doesn't move, the algorithms goes into the data, trains the models, and goes back and converge until you get the feedback loop, kind of trains until you get a good outcome and generalized models. So that's a kind of good concept to develop in that way.
And I think that technology is really good, federated, only because one part it definitely takes care of, right? The privacy part of it, it is local. So you have that confidence of, data breaches are definitely not a thing in that. So that's definitely a very nice new tech.
No, that's very helpful. Hadassah, you worked on high-risk applications in AI. What accountability framework should be there to make sure when we are rolling out AI applications in healthcare that they, protect patient confidentiality and data for our audience? Could you tell them?
Yeah, it's indeed true. Most of the organizations that we work with, right, when they come to us, maybe provide a little bit of context on kind of like how we support them in addressing some of the risks of high risk AI systems. One of the things that we do is provide assessments. We have built out assessments that allow an organization to understand like what requirements currently play within the regulatory landscape. That means including these bigger frameworks, and then depending on the context, say if it's healthcare, we would look at specific guidance, say if the FDA as an example, to the extent that this type of guidance exists, and then regulations or other pieces that consider AI but aren't necessarily AI-centric of themselves. And what we do is we translate these requirements into practical criteria and controls. So splitting all of that up into these are the things that you essentially need to do at both the organizational level, so assessing organizational maturity, and then at the system level based on a specific use case. So I think that is one way, at least that's what we hope at least, for an organization to be able to put the right accountability mechanisms in place. It essentially allows them to put in, to consider and figure out at different levels, be it as an assessment, be it as a roadmap, or one of the final things that we do is certification. They will understand what type of an overview of risks and controls do you have as an organization. And we've actually noticed that working together with a set of companies, not only in healthcare, but across the board, a lot of these organizations have a lot of work going on in implementing controls, but they haven't actually documented it properly. So when we sit in these conversations, and that's, I guess, where, getting back to what you guys were saying about, engaging stakeholders, engaging patients as an example through feedback, is also just engaging a whole team at the organizational level and understanding what are you currently doing, because that oftentimes, as I just said, right, it's not documented well, and I think that's one of the ways that we get them to sit down at the table and understand this is what we do, and they'll be able to communicate that externally as well. So that's one example. I think other ways of ensuring accountability also relate to inventorization. This is one of the pieces that we get a lot of demand around right now, especially when it comes to the challenges of doing that, making an inventory of the AI use cases that you have within your organization, right? Where do you start and where is the limit? How far do you want to go? Because AI is everywhere. So that's one of the pieces that we are helping our members with, trying to understand, right? What's that going to look like for you? And that, again, depends on the context. So healthcare may be different from energy. But I would say those are two elements. And I think just as a more higher level item here, this is continuously iterative, right? I was talking to you just before, and one of our discussion points, right, was where do you stop? And I think at this point there is no this is all just a means to an end, and the end should be to ensure that you have the right guardrails in place. And there, once you've completed X, it's not finished. You'll continue because the landscape is changing, both at the regulatory front and in terms of the technological developments and applications, especially that we're seeing. So it's a continuous process, but you've got to start somewhere. And once you have the right framework in place, once you have the right controls in place, it becomes a lot easier to make adaptations as opposed to say, we have to change everything up. So I think those are a couple of items that I would like to mention.
Yeah, I mean, I definitely like the point of placing guardrails in place, because I've seen that, especially with tech and when it comes to model development, a lot of new packages and APIs come into place, and then what people do, they directly use it on healthcare data. Some of them have privacy options out there, and people don't set it off or false. So what happens, a snapshot of your data goes to the company. So people don't realize such things, but it's a huge data leakage out there. It's patient data that you're working on. So such things. So I feel like it should definitely be put on the front end. Even before you work, again, comes into documentation. It should be there before you start working on anything. Let it be POC as well.
It's really just one thing to add. Thanks for sharing that. I think what's also really interesting is when we work, I'm coming at this from our experience with our members. One of the interesting things is that a lot of organizations really want to jump into assessing a use case, saying this is what we want to do, let's go through it. But they're missing this whole organizational piece, which, for us, it's also an iterative process, right? Nobody really has a very clearly established idea of where they should be going right now. But that organizational piece, understanding where you stand in terms of your own practices, your own policies, we were talking again about this, I feel like I'm going to be saying this a couple of times, about having an internal, governance committee or some sort of a board that is responsible for AI governance and responsible AI policy, whatever you want to call it. Having that centralized body that is able to be held accountable, at least to some extent, for what's going on at that organizational maturity, organizational governance level is really important before you even start thinking about all of that other. They're one and the same, essentially. They're linked together. They can't be seen as two separate items.
No, thanks. Shravanthi, you work with a lot of behavioral complex data. How do you make sure that you protect that data and also protect it from re-identification? Talk a little bit about that.
Yeah, before when we spoke about the other part of RWD, the first thing I mentioned was the issue with BH data, because that's the one which is so easy to, not so easy, but there is a scope of re-identification, no matter how much you try to anonymize it. One thing that we do might seem very simple, but we sort of go with data minimalization concept. If there's a problem out there, you don't need to get all the data that you know about that member and put it there. It's just increasing your scope because there's just too much exposure out there. So minimize that exposure to begin with and try to see, at least there's a way to move through that path. And I mean, of course, we use anonymization techniques, and we also have certain data oversight people out there who are experts of pH data, and they know about from where it comes. Are they able to use this anonymized data and still able to find who the member? We do those kind of test runs because it relates to a member experience out there, and one of our motto is having a better member experience overall and provide better member care. So yeah, I would say most of it on anonymization and minimalizing data redundancies. So that is main, which is again hard, right? Because RWD data is all about trying to find whatever markers about that member and just get to that dimension of a member profile to know or to predict anything. Let's say, what is the psych admission? What is the risk of psych admission for this member in the next 2 months? You essentially need a lot of data points for that. But yeah, we try to put it to the problem and scope it out in such a way that we try minimizing that. And we've seen better results with that as well. So I would say that those are the main things.
Well, that's very helpful. To make sure we kind of wake up our audience a little bit, we're going to do a little bit of a lightning round, which is basically ask our panelists to give a 1 or 2 word answer to questions, some interesting questions, and then we'll take some audience questions. And if you don't have questions, then I'll keep asking questions. So, Sigal, we'll start with you. What is the one technological advancement you think will revolutionize patient data privacy in healthcare?
So I mentioned it already, federated lens.
Yes.
Okay. So again, to you, what is the most significant limitation of current anonymization techniques in protecting patient privacy?
Again, that was already mentioned, that linking back. So there's linkages back to be able to identify those patients. So that's
Okay.
the key issue.
Hadassah,
Yes.
if you're okay.
Overall.
What's one ethical challenge you think healthcare organizations are not paying attention to when it comes to using AI with patient data? One.
Yeah. Thanks.
One.
I would honestly say that maybe not like ignoring, but I do think it's important to keep at the core is that healthcare at the end of the day, right, is a human-centric field. So keep that human-centric element in it. I think that's like a
Okay, and this is a question which I find very interesting, Hadassah. Should patients, some of you, have a right to economic gain when their data is used by AI companies? Should these folks make some money? Yes? No?
Yeah.
Maybe?
These questions are hard, Sanjay. I would honestly
Controversial.
say, yeah, it's really controversial. We could have a whole discussion around this. I would say no.
No. Okay,
yeah.
wow.
I say yes.
Fine.
See, there we go.
You say yes? Shravanthi,
Of course,
Shravanthi, what do
it
you
should
say?
go back to the system. Absolutely. Without a doubt.
Maybe.
No, if you were to pick between yes and no, Shravanthi, we'll tell them to edit this video for your employer.
I mean, I work for non-profit, so it's okay if you don't edit it.
Okay. Shravanthi, so for you, in one word, what's the biggest challenge to maintaining patient privacy in AI-driven healthcare?
Biggest challenge. There are a lot. When it comes to
One.
one, that is the hard part. Biggest challenge, I would say, is moving through these ever-changing algorithms with regulations that is way behind. Like no updation in that versus too much updation in this. Navigating through both and having that trade-off is a little hard, and yet maintaining the privacy.
I had said one, but okay, I'll try to rephrase
Push
for you.
it to one.
True or false, current regulations are sufficient to protect all their
No.
patient data?
No.
False.
False.
Okay. So this is for all of you. I'm going to start with Sigal. On a scale of 1 to 10, Sigal, how prepared do you think average healthcare, not NHS, average healthcare organization is to handle all of our AI privacy data? 1 to 10.
1 is low and 10.
Yep.
3?
We are all in big trouble. Shravanthi?
I would say like 4.2.
Man, you must have been a math major. You must have been a math major. 4.2. Oh my. How about you?
I'm going to be so annoying because I was so focused on not coughing, I missed the question. You have to tell me again.
Here are some cough drops, man. How prepared on a scale of 1 to 10 do
Yeah.
you think an average healthcare organization is to handle AI-related privacy concerns?
Yeah, I think I'm not necessarily in the right place to make that judgment. I think you both are definitely better to say that.
Take a
So I'm going to be
shot at
neutral.
that.
I'm going
These
to say
people are
5.
looking at you as an expert here, man.
I'll be a confident 5, I think, if I have to choose.
5.
So
Okay, well, that's not great. 4.23, 5. Again, Hadassah, starting with you. What's more important for protecting patient privacy? Better technology or better policies? One of them.
I honestly think better technology. I mean, yeah.
No, that's it.
Okay.
Shravanthi.
Policy.
Better policies. Sigal, I know your answer.
Do you?
Yep.
What is it?
Technology. You're in technology.
A bit of both, I think. Yeah. Okay.
Okay, finally. We'll start with you, Sigal. In the next 5 years, will AI make healthcare data more secure or more vulnerable?
More what?
Will
Secure
AI make data more secure or more vulnerable?
Vulnerable.
Vulnerable or secure? She's handling NHS data. I hope none of you are from the UK.
So I have to say, I hope secure.
Hope secure.
Yes.
Man, we are living on hope here. Shravanthi,
Secure.
secure.
I'm
Yeah.
following the gang. I'll say also, yeah, I hope more secure as well.
Okay,
It all
more
depends,
secure.
yeah.
There you go. Well, we still have some time for some questions from the audience. I hope you have some interesting ones. Try to stump our esteemed guests. You can ask them one-word questions or longer questions. We have a gentleman there, please. If you can,
Need a microphone?
I can give.
Oh, I can give.
My
Oh.
mic. We're running short of mics here.
And
Yeah, thank you. I hope this works. Sigal, you talked about federated learning quite a bit. We are just going through another FDA submission, and it's getting harder and harder. How do you see a regulatory part for federated learning?
In terms of your FDA submission for your product?
Any product, would the FDA be okay with this? Or any other regulatory body?
I think it really depends on the product, but yeah, I think that the regulation needs to reflect the fact that some of the technologies are advanced and other regulatory as well. So not just the FDA, so there's different categories in different countries. I would say that there's some work needed to amend some of these categories.
On the regulatory side? Or?
On the regulatory side, but companies do have to understand how they adhere to the limitations of for safety and security of patients' data and how they run it. And there are ways to do that in terms of how a gateway, anonymization, etc., as part of the product.
Yeah. Okay. I think you had a question.
Yeah, thank you so much. I'm wondering a little bit about when it comes to clinical application and uncertainty of model predictions. How do you decide how to communicate to clinicians the uncertainty of a certain model's prediction?
Yeah, that's a really good question. I think that what we need to do is, and Hadassah spoke about it a little bit, is when you're validating these algorithms, that needs to be a project in its own right, and the clinicians, we need to free up clinical time to really understand what it is they're validating and provide the right report back that can allow us as a hospital trust to feel confident that the right thing is being done for the patient. So I think that whole process of how we test and validate those algorithms and applications needs so we created a clinical safety protocol that you have to use now for validating these technologies because there's so many of them and it's hard to but it's also recognizing that it's time consuming and freeing up that time might mean money. So when companies come to us and say, oh, it's a free trial or it's a free, for 12 months, it's not free if we have to spend our time testing and putting the infrastructure in to network it in, etc. So that from a company point of view, it's important to understand that process as well. I think it needs to include the certainty, for sure.
Yeah, and it's also like problem dependent, right? Depending on this problem, definitely need to include it. But I feel like it's really problem dependent, and having to involve clinicians right from the beginning has really helped. So they understand how the process goes and how we look at the results, and they can in fact let us know this is how we want to be able to see that. So I've seen that being helpful.
All right. Well, this has been fantastic. I've learned a lot. I hope some of you have too. And if you have further questions, our panelists will be here for more questions. And I want to really thank our amazing panelists. Please give them a round of applause and thank you for being here.